This component of lecture covers a portion of the chapter 15 in your book when we're really talking about what the physiological kind of responses of the body are. So basically the discomforts or joys of pregnancy. So one of the most common things that we'll hear from people, especially in the first trimester, is fatigue, particularly common early and late stages as well. And then we just kind of encourage with that resting, napping, alternating, activity and rest, maybe using energy conserving techniques, that sort of thing. As pregnancy progresses and as the uterus enlarges, a lot of women will experience some dyspnea or difficulty breathing or catching their breath. Sometimes we can help this with a little bit of physical therapy, a little bit of posture improvement, light exercises and stretching. However, it's really super common for someone to get winded at the top of the stairs type thing. And part of that is just simply because of the physiological changes as the body adapts to having a baby in there. The lungs just not having quite the capacity they had, and so then waiting for that rib cage to expand. Once that happens or the baby drops, then typically they'll have some relief from that. We do say that sometimes people will have a lot of congestion, nasal congestion, kind of sinus type things going on, and that's due to the estrogen during pregnancy. So we recommend nasal sprays, humidifiers. Lightheadedness is fairly common, especially early on in pregnancy. That's something that sometimes we'll see with a little bit of anemia, but also we see it as they just kind of start to adjust to uh, that lack of return. So the progesterone dilates the blood vessels. The placenta is, definitely creating this blood reservoir within their body that doesn't have a high pressure system attached. And that's what causes that orthostatic hypotension. Of course, we want to make sure that we're not having any cardiac arrhythmias, abnormalities, that type of thing that might be causing lightheadedness or fainting. So we take it pretty seriously until we rule out that, and then mostly we're just encouraging a lot of fluids, sitting, standing slowly, that sort of thing. And then supine hypotension is what happens as the uterus grows and enlarges. The weight of the uterus, whenever someone is placed on their back, compresses against the vena cava, and then that basically slows all of the flow back to the heart. And so that's really common for anyone who's been laying on their back. So we do what we call either a side lying or a modified side lying, where we tilt someone either left or right, doesn't matter, we're displacing the uterus. In certain cases, like in the operating room, you may hear someone say, "I need someone to displace this uterus," and they'll be tipping the patient to the side. Or you can do it manually by holding the abdomen in a way that it relieves the pressure from that vena cava. So one of the first signs that we typically will see with supine hypotension is nausea, clamminess. Sometimes we'll see a spike in heart rate followed by a drop in heart rate in mom, and just a really unclear feeling of just being unwell and feeling nausea. A lot of times they'll vomit as their blood pressure drops. And so that supine hypotension is usually fixed just by positioning. You'll see us use that in labor and delivery a lot, but it's also why we instruct women who are pregnant not to lay on their backs when they sleep, to definitely do a side lying position. Another common symptom that we see during pregnancy is some swelling, some minor swelling that comes and goes. We typically will advise some light exercise, avoiding long periods of sitting or standing, alternating, activity and laying down, and then elevating the legs whenever possible, especially if they're on their feet a lot during the day. We also see that some people will experience some varicosities during pregnancy, and again, this is a result of that progesterone causing the uterus to relax, and that works on the smooth muscle. And as that hormone is produced by the placenta, it's so that the uterus won't contract and expel the baby. But at the same time, it still acts on all of the vessels that are in the body and relaxes those smooth muscles of that. So the blood flow return back to the heart is poor just due to a lack of tone in those veins. And then that's typically what will cause some pooling in some areas, and those will be those varicosities that we see. Typically can also be very painful and uncomfortable. Some people can actually get those varicosities on their labia, which is super uncomfortable. We recommend icing. Other things that we also recommend are going to be compression stockings. And we, of course, recommend those to help return that blood flow. So they should be a decent millimeter of mercury pressure back up. Other things that we see because of that extra fluid in pregnancy is temporary carpal tunnel syndrome. We see that with edema around the nerves of the wrist as they, especially if they have repetitive activities, but really it's just that swelling that's putting a pressure on it. Sometimes we find that people get some good relief from going to a chiropractor. Some wear braces. It just depends and varies. Headaches are common during pregnancy, but they aren't necessarily because of pregnancy. Sometimes they are. But headaches are something that we have to take very seriously because they can be a serious indicator of preeclampsia, which is gestational hypertension or a medical emergency basically for mom and baby where the blood pressure goes up too high. So anytime they present with a headache after 20 weeks, they generally need to be kind of really followed for a little bit to make sure it's not a blood pressure issue. Some people that have migraines will have them more frequently during, so it's good to get a good history of their headaches and whether or not they've seen a neurologist. There are some medications that we just can't give. So like normally they may take something like Imitrex or another medication that's fast acting for of course due to pregnancy reasons we may not be able to allow people to take the usual medication that they take. So oftentimes we'll treat with Tylenol, and then if that doesn't cut it, sometimes we'll do some caffeine. So sometimes you'll see us use some alternate headache medications that we don't use with normal populations. Keep in mind that headaches can also be sourced from strain on the spine. And so when we think about the displacement of kind of everything that's normal in their body and that changed kind of sense of balance and center of gravity, they tend to develop that lower lordosis and they may end up with more cervical strain. So sometimes the best remedy for headaches during pregnancy can be a physical therapy consult or a chiropractor that can help kind of alleviate, or a massage therapist that can alleviate some of the musculoskeletal issues that are happening that are underlying those headaches. So the discomforts of pregnancy just continue to go on, mostly as a result of hormonal changes and fluid retention. We see worsened vision, blurry vision, or dry eyes that can be a result of that. We have to really be careful with the blurry vision. If it's sudden onset blurry vision, it can also be related to blood pressure. And so that's something that we have to kind of suss out as we collect that history and determine whether or not this is an ongoing longer term issue or whether this is a new onset short term issue and we need to ensure that they don't have a high blood pressure problem. I've also seen pregnant women come in with detached retinas, and so again, another reason why, just sometimes when you're on the phone and you're triaging a phone call and they call with eye pain or blurry vision or something like that, a lot of nurses don't always take it seriously, but it is really important to get them in and get them treated so that they're seen by an ophthalmologist and that sort of thing. So usually the vision changes are minor, reverse typically in those first few months after postpartum. So if they have more blurry vision at night or in the mornings when they first wake up, that sort of thing, they typically don't need a prescription change. It typically will resolve itself. But anytime they report a loss of vision, blind spots, blurry vision, double vision, floaters, anything like that indicate abnormal complications. Either that torn retina, or it could be a high blood pressure issue, that sort of thing. So we really want to take those seriously when we're assessing them. Some of the other discomforts that we'll see is breast tenderness and as a discomfort in pregnancy, and we just encourage a well-fitting supportive bra, especially as the breast tissue thickens with glands and fills. It's going to be important that they know that their bra sizes are going to change. And then some people experience what we call Braxton Hicks contractions, and I know I talked about this in class. I'm gonna look around. I may have to go back to the store to find my equipment for this one, but I'd love to show you guys the difference between a real contraction and Braxton Hicks contraction. They're painful, they're uncomfortable, they're more like a cramping, and then they don't have any effect on the cervix or the outlet to let the baby, they're not in actual labor. So what we really want to say is with contractions during pregnancy, if we can't tell if it's labor or not labor, if there's spotting involved with it, then we're more concerned. But if they kind of rest for a little while, rehydrate, have a meal, that sort of thing, and those contractions go away, then it's not true labor. So false labor and true labor can sometimes be a little tricky, wobbly line to walk down. It's a very gray zone. But we do have a few kind of tricks up our sleeve to see if something is Braxton Hicks or true labor. And we'll cover that a little bit more in our labor and delivery slides here in a little while. So another common discomfort of pregnancy is increased vaginal discharge. We don't want people to use strong soaps, scented soaps, douching, and we do want them to report if they have foul odor, a color change in their discharge, or any sort of bleeding, spotting, that sort of thing. And then oftentimes they'll have urinary frequency. Incontinence is also a common complaint of pregnancy. Reassure the patient that these changes usually resolve after pregnancy. Sometimes we will spend some time working with them on Kegel exercises to tighten the pelvic floor muscles. And then sometimes we might send them to physical therapy, which is kind of funny because we always send patients to physical therapy, and they really do have so many programs to help people. So anything that has to do with muscle groups, physical therapy is really the way to go. And they usually have a good bladder program that they can work with people. And usually in some areas there's like a specialist who specializes in urinary incontinence. It's become a growing issue both during pregnancy and post-pregnancy over the last decade or so. And so it's become its own specialty. Other things that we see during pregnancy are going to be nausea and vomiting, very common in the first trimester, usually caused by the increased HCG levels. Other things that we see very commonly during pregnancy are going to be food cravings, food aversions. Oftentimes we'll see people suddenly being revolted by something that's fairly normal, like cooked meat or something like that. I always say those are probably more protective than anything. I think that there's some foods that people's bodies, that incense, the increased sense of smell and that sort of thing, really makes them more sensitive to things that might be spoiled. Also might make them more sensitive to things that their body senses are not going to be, or could potentially be contaminated, like raw meat or that sort of thing. So you'll see sometimes that people have some really strong odor aversions and food aversions. Pica or pica is the craving of non-food items, and so like if they're eating dirt, paint chips, that sort of thing, or if they think that something smells so good that they need to eat it, like the dirt smells so good they can taste it, that sometimes is associated with nutritional deficits. So it might be that they're low in calcium or magnesium, or they might be low in iron, that sort of thing. And so they oftentimes will crave some very unusual things. So it's important to collect information on whether or not they're having abnormal cravings. They also have increased saliva, and that's to help them swallow food, right? So they have all of that edema that's in their kind of laryngeal area that's due to the estrogen, so the collection of that third spaced kind of fluid. And so they produce extra saliva to be able to help them to masticate and swallow their food without choking. But the interesting thing is that then they're also seen to have an increased drooling sensation, and so we call that ptyalism. It's also very common for people to complain of heartburn during pregnancy. This is caused by some of those hormonal factors as well, from the slowing of the gut, the reduced peristalsis, from pressure from the fetus on and the uterus and everything, all the contents in the abdominal cavity, creating a lack of room for expansion for the stomach. So we usually will recommend that people avoid fatty foods, uh, avoid excess liquids with their meal. Try to focus on drinking their liquids between meals, and then to try not to lie down after eating. Avoid eating 3 hours before sleep, that sort of thing. And that slowdown in peristalsis from the progesterone is also causing a constipation. Commonly in pregnant women, it's due to that reduced peristalsis, increased water absorption in the colon, and so it just slows everything way down, and then everything bulks up. So for this, we recommend increasing fiber. Maybe adding prunes or prune juice, or more raw foods, fluids, and light exercise, and really pushing on the fluids. A lot of times, just drinking more water can help resolve some of that constipation. And then by light exercise, we're really talking about walking. Low back pain during pregnancy is also another common complaint. Pelvic tilt sometimes can help. Rocking exercises can help relieve pain. Tylenol, ice packs, that sort of thing to their back. Physical therapy, again, those sort of solutions are generally a little bit more helpful. And of course, due to the raging hormones, acne and dry skin are super common during pregnancy, which doesn't even seem to make sense because acne is more of an oily skin thing, and then they get dry skin in other places. But it's very, very common for people to have more breakouts than usual. So let's just do a little question here. A patient who is 10 weeks pregnant complains of nausea, vomiting, fatigue, and breast tenderness. Recommendations by the nurse should include A. Looking for over-the-counter medications to help with nausea and fatigue during pregnancy. B. Notifying the provider if the patient experiences severe headache or vision changes, such as blurred or double vision after 20 weeks. C. Letting the doctor know if the patient is unable to keep any food down, experiences weight loss, and is dehydrated. Or D. Eating small, frequent meals, napping frequently, and wearing a supportive, well-fitting bra. And the answer is D. Eating small, frequent meals, napping frequently, and wearing a supportive, well-fitting bra. Because those answers actually address the complaints that she brought up. So the nausea, the fatigue, and then the breast tenderness. Each one of these answers those in that same order. Although the other answers are not completely wrong, welcome to nursing school, right? Can I get an amen on that one? This one is the most right simply because it addresses those complaints directly. Okay, so let's talk about obstetric care providers and who provides those. So nurse midwives, sometimes they are FNPs first and then do midwifery. Others are midwives and do their certified nurse midwifery. CNM is usually their abbreviations. They attend births in hospitals, so sometimes they're the primary provider and then they just have a surgical backup with the regular OBGYN. Sometimes they work in standalone birthing centers, or which is usually like a small business setup, or they can work in patient homes and doing home deliveries. So nurse midwives start off as registered nurses, and then they go back and get advanced training. If they are just a CNM, certified nurse midwife, that means they went back for their nurse midwife. They can also go back to school and do a primary care nurse practitioner and then get their midwifery cert on that, or they can also do like a women's health primary care, which you'll see a lot, which is WHPC. In their abbreviation list, and then they also are certified as a nurse midwife then as well. So nurse midwives generally provide more holistic care for low-risk pregnancies, and they do this with the same or better outcomes than physician groups. But they oftentimes are confused with lay midwives. And lay midwives are primarily caring for people in their homes. They may be trained formally, so they may have a nurse midwifery degree, or they may be an apprentice. And sometimes they should require licensing in most states. They don't always start as an RN. And so the evidence is good that lay midwives provide good care when it's within their scope of practice. And then the physicians generally perform births in the hospital setting, They perform cesarean sections. They do operative vaginal births, which is anytime we use like a vacuum. And they care for low or high risk patients. And that's important to know that there's a specialty within that. That when you hear from a perinatalogist is a physician who's gone on and certified in caring for high risk pregnancies and deliveries. And then sometimes you'll hear the word doula. A doula is someone who attends the birth as a labor support person, and they are not responsible for the delivery itself. It's as if sometimes you'll see family standing in as a doula. Sometimes you'll see that people will hire a doula to help them through the laboring portion. And that oftentimes comes with some out of hospital appointments as well, but they'll pay. Typically, doesn't accept insurance, that sort of thing, and so it's usually a cash pay, but it's really done to support the birth experience. On the unit here, you'll have the experience of working with nurse midwives that are certified nurse midwives, that are women's health practitioners, and you'll see that they work very much in a team with the physicians. And there is no perinatologist here. That the closest one is in Billings, and so people that need to see a specialist due to a high risk pregnancy will drive to Billings to do so. We do have a standalone birth center that is run by a nurse midwife, and that is Kayla Wright's. I can't quite remember the name of it, and it's a great experience for patients that have low risk pregnancies, and they do water births and all sorts of things there. She's very knowledgeable and very education centered, and she sees people as a nurse midwife in that sort of setting all the way through their pregnancy. And if at some point she finds indicators that this person would be better off with a hospital delivery, then she will refer them to either another nurse midwife that practices at the hospital or one of the physicians. When you hear some nightmare stories about births that have gone wrong, oftentimes out in the communities there may be lay midwives who maybe had 13 children, and then they don't necessarily have a strong education as a nurse or in midwifery, but they're kind of self-educated and apprenticed along. And so sometimes you'll see that there's some poor outcomes that can sometimes happen because of that, especially if they practice outside of their scope. And we see this, as a model of care that, for the very best care, they should be referring up to the next level anytime that there's any sort of complication. Okay, so let's talk about prenatal care. The first prenatal appointment that patients have is typically like 90 minutes long. It is so in-depth. All of that health assessment that you did in health assessment class in 238, that is like exactly what is happening. They are doing all health history. They're determining the due date. They're figuring out what medications or supplements are being taken, what was taken during the beginning of the pregnancy. They're looking and assessing the psychologic responses, assessing for any risk of genetic disorders. There'll be lab tests like blood type, HIV, gonorrhea, chlamydia, and then all sorts of intense education on health promotion, on what to expect during the pregnancy, but also what signs or symptoms would be worrisome and when they would want to call for more care. So for prenatal care, as far as low risk patients, people that we have not identified any sort of pre-existing condition or genetic abnormalities or anything like that we've seen on testing, we generally will do prenatal care appointments about every month until about week 28, and then they'll go every 2 weeks, and then until they're almost a month out, and then like at 36 weeks they should be seen every week for prenatal care. And we're really checking for baby's growth at that point, and we're also looking at mom's blood pressure and whether or not there's glucose spilling in the urine, that sort of thing. And so that fundal height measurement that's in one of those videos, that's exactly why we're doing it, because we're measuring for sizes. And the other thing that we're doing is we're always checking fetal well-being. And, we do this through, assessing mom, but we also do this through listening to the fetal heart rate and determining whether or not it's in an acceptable range. And then still educating moms on kick counts and things that they need to know about the tail end of the pregnancy and planning for their delivery. So, some things that we want to follow up on when we assess people during pregnancy. Uh, Anytime that there's leaking of fluid from the vagina, if we're not sure what it is or where it's coming from, we're going to be investigating whether or not that bag of waters has broken, even if it's just a trickle. Anytime people have vaginal bleeding, we have some concern, and you'll see that we'll ask a series of questions, and the nurses are very astute at triaging vaginal bleeding. Reduced fetal heart activity, so anytime that the baby's heart rate slows down, a headache for mom that doesn't improve with Tylenol or acetaminophen. Anytime people have right upper quadrant pain, even if they have like dyspepsia normally, that right upper quadrant pain, one of the things that we can see is a slowdown of the gallbladder, and they're more likely to develop gallstones during their pregnancy. And so, if they present with right upper quadrant pain, we're generally going to need to do an ultrasound. Significant or severe vision changes, anytime they report persistent contractions or new onset low back pain that comes and goes. Sometimes people, if they're in early labor or preterm labor, they can have a sense of pelvic pressure. And that pressure can be indicative of preterm labor of the cervix changing or pressure from the fetus. But as pregnancy progresses towards the end, they can have that sensation of pelvic pressure and it not be a major concern. We're just really looking that that baby has dropped at the end of pregnancy. Menstrual-like cramps that come and go in the early part of that first trimester, if they're severe, that's all, especially if they're accompanied with vaginal bleeding. That would be another reason why we'd want to see people. And then burning, of course, when they pee. We don't want people to get urinary tract infections, and we want to treat those aggressively and early, typically in pregnancy, because of the accumulation of fluid in the kidneys, the hydronephrosis that sometimes naturally happens just from all of that progesterone, can make them a little bit less able to fight off those kidney infections. And bladder infections can oftentimes indicate dehydration and can be so irritable to the uterus that it could cause people to go into preterm labor or early labor. And so we do try to make sure that any sort of urinary dysuria is treated right away. And this last box on the prenatal care just talks about kind of the standard schedule of what we assess for in low risk pregnancies. So during the first trimester, we generally will do some blood work, and we're really looking at, in mom's blood, we're finding DNA fragments of fetal material, and so that's how they're testing for trisomies. They'll test for some plasma proteins, HCG as far as whether that level is up high. Ultrasounds typically between 11 and 13 weeks. For those, we're really looking at nuchal translucency, which is really measuring the space at the back of the fetal neck. And if it's super thick or thicker than what we expect to, it can indicate that there's abnormalities. And oftentimes those are congenital or genetic malformations and things that are going on, or syndromes. During the second trimester, so after 13 weeks, we're really looking for the integrated screening. We're looking for laboratory tests between 14 and 16 weeks. And then we'll oftentimes kind of look for a couple of things. Sometimes we'll look for alpha fetoprotein, which will tell us whether or not someone has maybe a risk of neural tube deficits. And some chromosomal abnormalities like Down syndrome. Sometimes we'll see those with some other trisomies as well. Then sometimes we'll look at, and it's really, not all of these tests are required during the second trimester. Moms can they can request out of these. They don't have to have them done. So for some people, the outcome wouldn't change what they're going to do with their pregnancy as far as completion. And so not every person wants to have all of these tests run. With the aging population that we have of geriatric pregnancies, basically over the age of 35, we are seeing an increase in testing for all of these disorders during that second trimester. And then somewhere again between 18 and 23 weeks, but typically right around the 20-week mark, we're looking to schedule people for a biophysical kind of ultrasound that really tells us whether or not the fetus is developing appropriately, that the heart chambers are working. It's really a whole anatomy and physiology check of that fetus for health.